Muy bueno, botenabino. Good morning. Salutations au nom de notre Seigneur Jésus-Christ et bienvenue à la deuxième session sur les soins de santé au moment de COVID-19. Nous sommes heureux que vous soyez parmi nous aujourd'hui. Greetings in the name of our Lord Jesus Christ, and welcome to the second session on healthcare in the time of COVID-19. We are glad that you are with us today. Our program on healthcare concludes this week with a review of the impact of racism and discrimination, as well as American paternalism has had on healthcare systems in both the United States as well as the Congo. We will also have two presentations on the future of healthcare in a post-COVID-19 world. Notre programme sur les soins de santé se termine cette semaine par un examen de l'impact du racisme, de la discrimination et du paternalisme américain sur le système de soins de santé aux États-Unis et au Congo. Nous aurons également deux présentations sur l'avenir des soins de santé dans un monde post-COVID-19. Après les présentations que vous allez suivre, nous aurons un temps pour questions et commentaires. Voulez-vous les envoyer par conversaire à Question Charlotte White ou par email à questions4cmn@gmail.com. Following the presentations you're about to watch, we will have a time for questions and comments. Please send them by chat to Questions Charlotte White or by email to questions4cmn@gmail.com. Thank you. Bienvenue.
And now for our first presenter on the racism issues, we have Dr. Mireille Mimikanda, a retired pediatrician, past director of Health and Disability Services at the Head Start Bureau, past director of child protection at Children's Hospital in Washington, D.C., and past deputy director at the National Institutes of Health as director of the National Center on Minority and Health Disparities. Since 2016, she has served as senior advisor to the Dikembe Mutombo Foundation, where she assisted in the launching and management of the Biamba Marie Mutombo Hospital in Kinshasa. She is Haitian-born and holds degrees from American University, the George Washington University School of Medicine, and the Johns Hopkins University Bloomberg School of Public Health.
Hello, it's a pleasure to be with you today to discuss a subject which is very complex and that requires much more than the time that we have together. Our new reality is very different from what it was a year ago, from wearing our masks to having virtual meetings. A unique year indeed. Under the shadow of the pandemic of COVID-19, we are now looking at the consequences of the death of George Floyd and others and the reality of the Black Lives Matter movement. We realize that racism has a great impact on our lives and the way we treat each other. We want to be reminded that there are fundamental truths that are always there with us: our love for God and the commitment to love our neighbor as ourselves. This means not only our next door neighbor, but all the people with whom we come in contact on a daily basis. Yes, things are changing, and change is challenging and sometimes uncomfortable. It requires that we go beyond what we are used to. On the wind of change, 69% of Americans believe that racism is a big problem in America. Even the Webster Dictionary is expanding its definition of racism. We are understanding that racism is more than an individual failing, but rather a systemic construct built by society. We are looking more clearly at the issue of white supremacy, which presupposes that one group is superior to others and deserves to have advantages that the others should not have. Let's look at the definition of racism in Wikipedia. Racism in the United States has existed since the colonial era, and it involves laws, practices, and actions which discriminate against various groups or adversely impact them in other ways based on their race or ethnicity. Formal racial discrimination was largely banned in the mid-20th century, and over time it became to be perceived as being socially and morally unacceptable. When we look at the intersection of racism and health, some things become very evident. What is clear is that racism has an impact on health and that it causes health disparities. Health disparities are not new. What is new is that they present a problem. The American government, through the Department of Health and Human Services, has recognized this problem and discussed it in a series of major reports, starting from the Heckler Report in 1985 all the way to Healthy People 2020, which has specific goals to address disparities. Health and healthcare are distinct but closely related, and they join in creating, with racism, the poor outcomes that we can see as health disparities. Health and healthcare disparities are differences in health and healthcare between groups that are closely linked with social, economic, and/or environmental disadvantage. Disparities occur across many dimensions, including race, ethnicity, socioeconomic status, age, location, gender, disability status, and sexual orientation. Race is not the only factor affecting disparities, but racism is a major cause of disparities. A major issue in understanding this universe is discrimination. What is discrimination? It's a socially structured action that is unfair or unjustified and harms individuals and groups. The impact of discrimination occurs at both structural, meaning societal level, and at an individual level, which means negative interactions with specific people, like salespeople or even fellow passengers on a bus who move away from you, or the taxi driver who ignores you to stop a few steps beyond you for a white person ahead of you. Discrimination is often measured by either everyday humiliations or major discriminatory events, like being denied a loan by a bank because of your race. As an example, a young black man is familiar with the look of alarm that may show on the face of a salesperson when he comes into a store, and how he may be followed around and repeatedly asked what he wants to buy. Discrimination may be invisible to people who are not subjected to it, but it is plain and very painful to its victims. Researchers have tried to understand the impact of racism and its relationship to health disparities. There are at least 3 big research models. The first one is the study of chronic and repeated stress that racism and discrimination cause. Chronic stress leading to chronic conditions like hypertension, diabetes, obesity, and inflammatory diseases. The second model is the model of social determinants of health. Health exists in the context of the broad environment in which we live. That includes access to good food, water, housing, the quality of schools, workplaces, neighborhoods, and the composition of social networks and relationships. The third model is the brain impact model. The impact of unrelenting discrimination on the brain affects self-regulation and leads to things like hypervigilance and negative coping behaviors like overeating, alcoholism, mental disorders, substance abuse, etc. These outcomes are often seen in populations that are oppressed. Let's look at some examples of issues that lead to health and healthcare disparities. Let's start with a lack of access to healthcare and healthcare facilities. This means this may be caused by financial constraints or by geographic location. Discrimination would be another example, and we have mentioned it before, but it also includes implicit bias. Implicit bias is a more subtle and sometimes unconscious reaction to a certain group of people. It means how you are treated by a provider of services, who may think that because you are for a different racial group, you cannot understand complicated instructions, and who does not even bother to give you a new type of medicine that works better than an old one. The next example is inferior care. It has been shown that discrimination leads to poor and inferior care. For example, a black woman with a serious abdominal pain problem may be ignored by racist caregivers and denied the pain medication that they would readily give to a white patient. All those examples show what can transpire and how poor outcomes are created. How do we prevent and access or address health disparities due to institutional and individual racism and discrimination? Unfortunately, we do not have enough time to do justice to that discussion right now. But let's start anyway. We have to begin with self-awareness, and we have to recognize our own biases, face them, and be open to them and address them. We have listed 7 steps forward. Let's go down our list. The first step is poverty eradication. This deals with the social determinants that we have mentioned earlier, the environmental, economic, and cultural determinants that accompany the social ones. The second step is improve access to healthcare services. And that's where things like transportation and health insurance coverage come in. The third step would be an increased concordance between patients and providers. When they speak the same language, when they are from the same community and they are culturally compatible, this leads to better communication, trust, and better compliance. Ultimately, better outcomes. Provider training on implicit and explicit bias helps, particularly if the providers and the patients are different or discordant. Improved quality of care. Provider training helps improve quality of care and better leads to positive responses to the specific needs of the patients and community. And now let's address community outreach. The education of patients and the community lead to lifestyle changes and better outcomes. The patients can self-advocate and be the best advocates for themselves. Finally, health workforce development. There is a great need for a more diverse group of providers as the country becomes more diverse. And this has multiple benefits that extend over time and across populations. As you can see, there is much to be discussed and to be accomplished. We have only scratched the surface. I thank you for your attention, and I look forward to continuing this conversation with you at another opportunity.
Our next presentation on the subject of racism and tribalism and the impact on health will come from Dr. Pt2. He is the medical coordinator of the CPC Congo Presbyterian Community and medical officer in charge at the Boulapé Hospital.
Bonjour, chers membres et téléspectateurs du Congo Mission Network. Je suis Dr. Chanza Mikobi, le médecin coordonnateur du département médical de la 31e CPC. La 31e CPC a au total 11 hôpitaux en République démocratique du Congo. Ces hôpitaux sont répartis dans 3 provinces de la République démocratique du Congo. 6 hôpitaux dans la province du Kasaï central, 3 hôpitaux dans la province du Kasaï et 2 hôpitaux dans la province du Kasaï oriental. C'est dans ces 3 provinces où il y a eu des vifs combats et des violences intertribales. Nous citons les combats de Nganza, des chefs Kamwina Sako, de Djibaya dans la province du Kasaï, les combats de Bakwankenge, de Kankenge, de Mweka, de Luebo, de Tikapa et Kamoni dans la province du Kasaï, les combats de Kabe Kamwanga et de Dimbelenge dans la province du Kasaï oriental. Nous signalons ici que ces combats et conflits intertribaux ont entraîné des vrais problèmes ou bien des sérieux problèmes dans différents secteurs des vies humaines, notamment les secteurs de la santé. Les secteurs de l'éducation, les secteurs de l'agriculture, les secteurs de l'économie et les secteurs social. En rapport avec l'impact des combats violences intertribales sur les hôpitaux, la formation des professionnels de la santé et les prestations de services, D'une façon générale, les combats et violences ont entraîné un impact négatif en court, à moyen et à long terme. Pour ce qui concerne les hôpitaux, l'impact négatif est caractérisé par la perte des infrastructures sanitaires pendant les affrontements. Par rapport à la formation des prestataires de la santé, cet impact négatif est caractérisé par la faible production des ressources humaines pour la santé suite à l'insécurité, la discrimination, le tribalisme et la pauvreté de la population. À ce qui concerne la prestation des services de santé, l'impact négatif est caractérisé par la sous-utilisation des services de santé suite à la destruction des infrastructures sanitaires, la migration de la population pendant les affrontements, agression des prestataires sanitaires par les milices, non-approvisionnement des formations sanitaires en médicaments et réactifs des laboratoires par les partenaires internationaux. Et nous signalons aussi que les tribalismes ainsi que la migration de la population pendant les affrontements ont entraîné les différentes épidémies telles que l'épidémie de malaria, malnutrition aiguë sévère, les épidémies de fièvre typhoïde et voire même les épidémies de la diarrhée et également aussi la violence sexuelle. Quant à l'impact de l'injustice en République démocratique du Congo, voici quelques éléments de l'impact de l'injustice. Il y a eu prolifération anarchique des partis politiques, mauvaise qualité de services dans tous les domaines suite aux mauvaises sélections de prestataires, impunité, le favoritisme, la guerre tribale ainsi que la perte des vies humaines. Quant à l'impact de l'histoire du paternalisme américain au sol congolais, ce paternalisme a engendré les impacts négatifs et positifs. Quant aux impacts positifs, il y a eu la dotation de plusieurs bourses de titres, surtout pour la formation des infirmiers en différents domaines. Il y a eu la construction et la dotation des infrastructures en matériel et équipement. Du point de vue négatif, le paternalisme américain a donné les points ci-après. La discrimination raciale, la faible considération et traitement des peuples congolais. Aucune industrie américaine sur les sols congolais et il y a aussi l'imposition sur les plans politiques. Quant à l'impact des simples préjugés tribaux, cet impact est négatif car les tribalismes, les combats et violences intertribales ont occasionné l'injustice sociale, ce qui s'est traduit par la discrimination dans la sélection des personnels médicaux dans tous les domaines, prolifération des partis politiques anarchiquement, et qualité douteuse des services dans tous les domaines. Il y a eu aussi le favoritisme ainsi que l'imputation. Quant à l'impact des combats violents sur la préparation, les traitements de Covid-19, ici nous signalons que ces conflits n'ont pas engendré aucun impact. Au contraire, ils ont entraîné la recrudescence des épidémies, étant donné que le système de la santé est généralement paralysé. Nous allons faire quelques suggestions. Il y a eu des suggestions d'une façon générale et les suggestions en rapport avec le Covid-19. D'une façon générale, nous pensons organiser les cadres de concertation avec les leaders sur la résolution des conflits. intensifier la sensibilisation sur les effets négatifs des conflits, assurer l'assistance sociale des personnels vulnérables, construire les structures sanitaires dans les lieux non couverts, assurer la formation des médecins et infirmiers en santé publique pour une meilleure prise en charge des épidémies, assurer la réhabilitation des infrastructures sanitaires détruites pendant les différents affrontements, doter les formations sanitaires en matériel détruit, surtout les frigos pour la conservation des vaccins. Que les peuples américains assurent un bon traitement des peuples congolais. En rapport avec les COVID-19, ici, nous avons retenu d'intensifier la sensibilisation en rapport avec les COVID, assurer la surveillance épidémiologique à base communautaire et non communautaire, doter les personnels de la santé en équipement de protection, aménager les cadres d'isolement des malades suspects dans les formations sanitaires et puis assurer la prise en charge financière des personnels médicaux. Je dis et je vous remercie.
Our next presenter with reflections on the future challenges and opportunities in a post-COVID world will be Dr. André-Jacques Neuzy, the co-founder and senior director of the Training for Health Equity, or the NET project. He is an honorary associate professor of medicine at New York University School of Medicine, where he co-founded and directed a cross-disciplinary center for global health. A leader in health workforce education, Dr. Neuzy has consulted on health workforce development for academic institutions, governments, bilateral agencies, and international organizations. He spent much of his childhood and youth in the Congo, in or near the city of Congo, where his father was a Protestant chaplain with the army.
Hi. It is a special pleasure for me to be part of this series of discussion. I want to thank the organizer for inviting me. And it has a special significance for me because I have a very special bond with the Democratic Republic of Congo, and more specifically with the province of Kasai, where I spent my childhood and adolescence in the city of Kananga. I am the senior director of the Training for Health Equity Network, or the NET, an international partnership of academic institutions committed to train health professionals with a sense of dedication to serve where the needs are the greatest. Our academic partners are located on 5 continents, and they work across sectors. And what is the common thread between them is that they are community engaged and work with the community they serve with a focus on the underserved. COVID-19 has hit an unequal world riddled by inequities and inequalities, and it is not only a health crisis, it is a human crisis affecting the very fabric of our society. It has highlighted the existing inequalities not only between industrialized nations and developing countries, but also within wealthy countries where racial minorities and lower social economic classes are disproportionately affected as a result of ongoing discriminations that prevented them from having fair opportunities. This pandemic is a massive challenge. It highlights the urgency for a multi-sector approach needed to align and coordinate health systems with other sectors, such as public health, social services, education, transportation, sanitation, and other essential utilities frequently undersupplied in poor countries. The pandemic also caught our health systems unprepared. Poor, under-resourced regions with feeble health systems have been hit particularly hard. Our organization, the NET, primarily focus on the education and retention of health professionals in areas of need, as I mentioned. But it has long recognized the need for a more effective integration between education, health, and social systems, whether in developed or developing nations. We work with partners in different African countries, including the Democratic Republic of Congo, where we collaborate with 2 universities located in the eastern part of the country, in the province of South Kivu, in the city of Bukavu. They are the Université Officielle de Bukavu, or the State University of Bukavu, and l'Université Évangélique d'Afrique, or the Evangelical University of Africa. In 2018, at their request, our organization conducted an assessment of their priority need, the needs of these institutions. Both universities have a School of Medicine and Health Sciences and a teaching academic hospital. These 2 hospital centers are the most important referral healthcare facilities for the city of Bukavu and the entire province. They provide the education and clinical training to future doctors, nurses, midwives, public health officers, and other health professionals, as well as they deliver the medical care to their population, carry out research, and public health activities. The evaluation revealed how the lack of a stable source of electricity affects negatively the training of healthcare professionals, the development of their own faculty in their teaching duties in the hospitals and other clinical sites, as well as the delivery of healthcare services themselves. These institutions, as you very well know, share similar conditions as those in the rest of the country. The majority of hospitals and universities in the DRC face the same issue, namely an unreliable provision of essential utilities such as electricity, drinkable water, the disposal of biomedical waste, and access to broadband internet. These utilities are essential to ensure the good functioning of health systems and educational institutions. Of course, for example, the 2 campuses in Bukavu and their hospitals are frequently facing daily interruption of electricity, making them dependent on costly and polluting diesel generators. This has a direct impact on essential services, such as the maintenance of cold chains for vaccination, the functioning of laboratory services, and the functioning of clinical equipment necessary for patient care. The lack of a steady supply of electricity impacts negatively the development of the IT infrastructure and the development of digital platforms vital for public health surveillance systems. Public health surveillance systems, particularly these days, require accurate and timely data collection and analysis, and the capacity for sharing vital data locally, regionally, nationally, and with the rest of the international global health community. At the time of COVID, lives depend on building an effective online surveillance system. And it is essential for these educational and health centers to have also the capacity to develop and implement e-education, electronic education, and electronic health, e-health programs. These institutions also lack adequate libraries. Their libraries are grossly inadequate. And in the midst of COVID-19, they still don't have a safe water and sanitation system that is essential for preventing the spread of disease. The hospitals and clinics also lack a safe and adequate biomedical waste disposal system. So, to address these priorities, our organization, in partnership with our two local partners, these two universities, and with a French non-for-profit organization called Scale, have developed a project in collaboration with local and international companies and other partners, with the support of the Congolese government, of course. These projects consist of a feasibility study of integrated and replicable legal and contractual solutions aimed at achieving an economy of scale in providing essential utility services that are technically and economically optimized to meet priority needs of the health and educational systems of the city of Bukavu. The project will provide the necessary infrastructure for academia, local authorities, and healthcare providers to benefit from digital advances and online resources. By having access to stable and sustainable energy, local partners will be able to strengthen data collection, analysis, and dissemination, obtain diagnostic tools online, in particular by using artificial intelligence, enable students, teachers, and healthcare providers to participate in online and distance learning activities, to have e-education and to have e-health, and to have access to an electronic library. Integrated and decentralized infrastructure management will strengthen local and global coordination, will strengthen preparedness and response to pandemics and other disasters to come. The COVID-19 pandemic underscores the need to rethink the concept of health in the larger societal context. A big lesson from COVID is that this pandemic is exacerbating the disparities and the inequities in health outcomes. It has the heaviest impact on the lives of people living in deprivation or facing difficult socio-economic circumstances. Socially and economically vulnerable population, as you know, suffer disproportionately. Let's remember, this is really important, let's remember that good health starts in the community, not in the clinics, nor in the hospitals. In the long term, we must reconsider the kind of health system that is capable to protect everyone, whether in time of crisis or not. We need to rethink what is a health system that works for all by moving from inpatient hospitals to strengthening primary care in the communities where people live. We must make smarter investment, moving from spending big dollars in hospitals to where it counts most, the community. We also know that health is determined to a large extent by what is called the social determinants of health that are responsible for 90% of individual longevity. For example, housing, food, education, access to water and sanitation, employment, transportation, and so on, are determinants that really are responsible for 90% of the length of the time we will spend on this earth, whereas the biomedical determinants account only for 10 to 15%. To tackle these and to tackle these health inequities, health professionals must develop alliances across sectors and work proactively with community partners. Lastly, I would like to share a couple of reflections with you. We can all see that the measures needed to be taken to stop this pandemic will not work in isolation. They will require global solidarity and global cooperation. We are only as strong as the weakest health system in this world. We also hear that there is a so-called post-COVID new normal, as if context doesn't count. We must recognize that poorer countries face their own specific issues, and they cannot be prescribed by wealthier countries actions that don't fit their context. Public health and social measures have demonstrated that they are effective in limiting the spread of COVID. There are physical distancing, local lockdown and confinement, schools and business closure, but their direct applicability in many poorer countries where economic and social conditions are widely diverse and dissimilar from ours, their applicability remains unclear. African countries must be supported in generating the evidence, their evidence, in their own context, to develop their policies and strategies to limit the social and economic disruption caused by the pandemic and prepare for the next crisis. COVID is a precursor of things to come, and these things will happen. However, I remain optimistic for the future. The COVID pandemic is an historical opportunity for change. It is an opportunity to get rid of the old normal, and in this regard, the Sustainable Development Goals agreed by the United Nations are paving the road to build a better, more equitable and sustainable world where no one is left behind. Thank you very much. Merci. Secrétaire.
Our final presentation with reflections on future challenges and opportunities in a post-COVID world will come from Dr. Serge Makolo Kazadi, current director of the IMCK and chief director of the Chikaji Health Zone, and former medical director and chief medical officer of the Bilomba Health Zone. He has a medical degree from the University of Lubumbashi, a diploma as specialist in public health from the University of Lubumbashi, and a certificate in scientific research from the Free University of Brussels and the Catholic University of Louvain. He was born and raised in Kinshasa, and he is married to Mrs. Bertha Chilomba and is father of 5 children.
Hi everyone, my name is Dr. Serge Makolo. I'm from the Democratic Republic of Congo. I live in Kananga. I'm the director of IMCK, which means the Christian Medical Institute of Kasai. It includes 4 main departments: the medical department with a hospital and a polyclinic, the education department with 2 nursing schools, the community health department, and the hydroelectricity department with a dam. My presentation will focus on 3 points. First, on our healthcare system profile before COVID-19, then on the opportunities of our healthcare system after COVID-19, finally, on the challenges of our healthcare system after COVID-19. To begin, let's look at what our healthcare system was like before COVID-19. I'm going to talk about 2 key aspects: the universal health coverage, and the financial protection. Several reports reveal that more than 70% of Congolese lacks access to the essential healthcare services, both in terms of geographical and financial accessibility, especially mothers and children. According to WHO, there is a lack of qualified staff, a lack of medical equipment and materials. For example, in my province, we don't have a surgeon. In my country, before COVID pandemics appears, we had only 50 resuscitation beds, while in Algeria, they had more than 2,000. We had only 10 respirators, while in Morocco, they had more than 3,000. Evidence shows that in DRC, the majority of the staff have symptoms of burnout. Their mindset and behaviors are affected. The government resources allotted to the healthcare organization is about 10%, and most of Congolese have to pay around 10% of their household budget in healthcare, so that the catastrophic health expenditure is estimated between $20 and $40. In this context of gap in health service coverage, the COVID-19 appears. Like a storm, it sweeps everything in its path. People get ill and die. Schools close. Employees lose their jobs. The healthcare system is under pressure. COVID-19 exposes our healthcare system weaknesses. There are lessons learned from this pandemic of COVID-19. It's very easy to lose the hope over this negative event. This is the dark side of COVID-19. But let me tell you something. Every coin has two faces. And also, crisis is often what drives successful change. I mean that at every tragic situation, it's very important to analyze the situation for a better future. That's what I would like to call the upside of COVID-19, the opportunities of COVID-19, or the bright side of COVID-19. We have to ask to each other this question: what worked and what didn't work? Today, we are able to manufacture masks, to manufacture respirators. We can meet virtually. Like a mirror, the COVID-19 pandemic opened our eyes, not only to show us our weaknesses, but also to discover our abilities. We are able to teach online. Behind these opportunities, there are many challenges. How can we improve our healthcare systems as long as the majority of Congolese cannot access to the basic health primary cares. How is it possible to improve our healthcare system when we have no surgeon? How is it possible to improve our healthcare system when we have no qualified member, when we have a lack of medical equipment and materials? But let me tell you two things. There is a light behind the COVID-19 pandemic tunnel. And also, just because something is difficult, it doesn't mean it's impossible to do it. God bless us. Thank you.
To thank our presenters today for their very thoughtful and informative presentations. Nous remercions nos présentateurs aujourd'hui pour leur présentation très intéressante et informative. Maintenant, nous sommes prêts à répondre à quelques questions. We're ready to respond to some questions. The first question will come from Herb Long. He has two questions. I'll ask Herb, I'm going to ask you to ask one and let it be translated, and then we'll come back for the second. Is Herb there?
I'm here.
Okay. Ask your question, please.
There we go.
Okay.
All right. Now you're challenged me to remember my two questions, but the first one was I was intrigued about the comments made about the Americans maybe discrimination, or I'd like to hear more about maybe the Americans' mistreatment of the Congolese in today's environment. Just intrigued by that, and so that was by the second speaker, and I would just like to hear more about that.
Okay, thank you, Herb.
Ma question
we'll have a
est,
translation. Yes, allez-y.
ma question est, c'est plus ou moins un commentaire. J'étais un peu perplexée et intriguée par le commentaire qui parlait de la discrimination américaine. J'aimerais savoir comment est-ce que les Américains maltraitent ou discriminent, comment est-ce que les Congolais sont discriminés par les Américains dans cet environnement, dans l'environnement présent.
OK. Nous demandons à Dr. Paco de répondre s'il est là.
Dr. Chianza.
John,
Oui.
okay.
Merci pour la question.
Thank you for the question.
Thank you for the question.
Dr. Chianza.
Oui, je vous écoute, Bill. Oui, allô?
Oui, allô? Il vous a posé une question?
Oui, la question est bien saisie, merci beaucoup. Vous avez parlé de la discrimination que les peuples américains ont fait par rapport au peuple congolais. C'est ça la question?
No.
So your
Hello?
question, if I understood your question correctly, you are talking about or wondering how does the American people are discriminating, how our Congolese people are being discriminated against by American people. Is that correct?
Did you write it down in the chat?
Oui, c'est juste, nous avons constaté que l'institution, s'il y a une institution qui est dirigée par un Américain dans le sol congolais, une fois que l'Américain est parti, tout tombe par terre. Tout tombe par terre et l'institution là tombe puisque l'Américain est parti.
So we just noticed that when there is an American institution in the Congo, if there is any issues, any troubles, the American will leave. And what happened is that the institution becomes abandoned. So it's every man for himself in the Congo. Allez-y.
Je disais que une fois que l'institution qui est dirigée par un Américain dans le sol congolais et l'Américain là est parti, tout tombe par terre. Tous les subsides qui venaient, ça ne vient plus. Bon, on a constaté que ça, c'est une discrimination puisque lorsque leur frère est là, et la dotation de l'institution est vraiment utilisée et fonctionne correctement. Lorsqu'il n'est plus là, et tout tombe par terre. C'est dans le sens là qu'on parle de la discrimination.
Un moment pour la traduction.
OK.
Okay.
Dina?
All right, you ready? So when we're talking about discrimination, what we mean is that when there is an American institution present in the Congo, when the American is there, everything is functioning well, the funding is there. But as soon as the American leaves, it's every man for himself, and the institution is pretty much abandoned and things are no longer working correctly. So that is in that sense when we're talking about discrimination.
Je voulais encore ajouter quelque chose.
And I wanted to add something else.
Et aussi, les traitements, on est dans une institution où il y a les Américains, les traitements ou bien les salaires pour les Congolais est toujours inférieur par rapport aux Américains. C'est dans le sens là que nous parlons de la discrimination. Cela veut dire que les Congolais sont moins considérés par rapport au peuple américain. C'est dans le sens là.
And also another thing is regarding salary or pay. It's whenever there is an American institution in the Congo, the Congolese gets paid less than the American. So that is another type of discrimination that we're talking about.
Okay. Your second question, Herb.
Votre deuxième question?
You asked about training of.
Il n'y a pas une deuxième question. S'il y a une deuxième question, je suis là pour répondre.
Oui, elle arrive. La deuxième question.
Yeah, I was curious too. I've had 2 or 3 questions. I don't think I can remember the second one, but I was intrigued about the the discussion about the needs, the medical needs, and what's the status of training of Congolese medical personnel? I mean, I'm assuming it's a lack of training, not the availability of people wanting to get into the medical field. I mean, is this an area where the international community can significantly help? I mean, in the training.
Give me just a moment. All right. Ma deuxième question, c'est au sujet de la formation médicale, du personnel médical. Quelle est la situation courante au Congo vis-à-vis de la formation médicale? Est-ce que j'assume que c'est le manque de formation plutôt que le manque des gens qui veulent recevoir cette éducation médicale?
Est-ce que c'est dans ce domaine que la communauté internationale puisse aider?
Qui peut répondre?
Oui, je peux ajouter. Le problème, ce n'est pas uniquement manque de personnel. Les personnels sont là. Il y a un problème de la pauvreté d'abord.
I can add, the problem is not the lack of personnel. It's the first problem is poverty.
La pauvreté de la population. Et puis, en dehors de la pauvreté, lors des affrontements de la guerre, il y a eu beaucoup de problèmes par rapport à la production. Les Congolais, la plupart des Congolais vivent des activités champêtres, de l'agriculture et tout ça. Mais lorsqu'il y a eu des combats, lorsqu'il y a eu beaucoup de problèmes, des conflits, les gens n'ont pas cultivé, les gens n'ont pas produit pour scolariser leurs enfants. C'est ce qui pose aussi un problème par rapport à la formation du personnel. Et en dehors de ça, il y a la formation du personnel n'est pas assurée uniquement par...
Un moment, docteur, pour la
Oui,
traduction.
pour la traduction. Et à part la pauvreté, beside poverty, there is also conflict in times of war. For example, when you have a time of war, when you have conflict, there is problem with production, things such as farming or agriculture and all. And when there is conflict, people cannot educate their children. Et allez-y.
Et je disais, à part la pauvreté, lors des affrontements-là, beaucoup de gens ont fui en brousse. Ils ont fui en brousse, ils n'ont pas pu supporter les coups des balles. Et même les partenaires internationaux qui arrivent pour appuyer les personnels de santé dans les plusieurs thématiques, ils ne sont pas venus, ils ont eu peur aussi de la guerre. C'est ce qui a fait qu'il y a eu une sous-production de personnel de santé.
So people, during conflicts of war, people run to the forest, they cannot stand, they are afraid of the shooting, and even international organization, they cannot remain in that location. So therefore, that causes underproduction or lack of production, and also lack of medical profession training.
Okay, thank you. Merci beaucoup. La prochaine question vient de Janet Sullivan. The next question comes from Janet Sullivan. Jan, who would you like to answer your question?
The person who was discussing the impact of tribal conflicts on the healthcare system.
Okay.
La personne qui, j'aimerais poser ma question à la personne qui avait parlé des conflits intertribaux.
C'est le Dr. Pacio. So ask your question, Shannon.
Allez-y avec votre question.
I understand the church has attempted to address tribal conflicts in some areas. I wondered what they had done and what the government also has done to address intertribal conflicts.
Ma compréhension est que l'Église a essayé de régler ces conflits intertribaux. Et ma question est, qu'est-ce que l'Église a exactement fait et aussi qu'est-ce que le gouvernement a fait pour éviter ou pour résoudre ces problèmes, ces conflits intertribaux?
Et je pense que l'Église a fait un grand travail dans la sensibilisation et dans l'éducation de la population sur les effets négatifs de la conflit et des conflits plutôt, mais également aussi.
Donnez-moi juste un instant. I'll say first that the church has done a lot. The first thing is that they've tried to mobilize the population and educate them regarding intertribal conflicts.
Également aussi, aujourd'hui, lorsqu'on vous parle aujourd'hui, dans la province du Kasaï central, le gouvernement a envoyé les ministres de l'Intérieur pour une concertation entre la province, donc les conflits de Ndemba et de Bakwangenge. Je pense que le gouvernement, donc tout le monde est sur place, toutes les parties prenantes sont sur place pour mettre fin à ces conflits.
Oh, je ne vous ai pas bien entendu. Est-ce que vous pouvez répéter, s'il vous plaît? Ça crachait un peu.
Je dis que le gouvernement aussi est en train de résoudre un problème. Aujourd'hui, même là, il y a le gouvernement national qui est dans la province du Kasaï pour mettre fin au conflit qui existe entre les territoires de Bakwangenge et de Ndemba.
Okay. As of today, in Kasai, in Central Kasai, the government is actually trying to engage in some talks between the minister of the Homeland Security Minister to try to end these conflicts between two tribal groups. And he mentioned the
Ndemba,
the Bemba and the
Bakwangenge.
All right, so between those two tribal groups.
Okay. We have a question from Elizabeth Turk. Elizabeth, would you ask your question, please?
Elisabeth, pouvez-vous poser votre question? Nous avons une question d'Elisabeth.
Thank you very much. And actually, I think my question may have just been answered, but I'll ask it anyway in case there's more that can be said on the subject. My question is, I'm interested in hearing about how racism is happening in Congo among the Congolese. Is discrimination, racism disproportionately affecting certain populations? What can be done about this? And some answers were just given. And also, how's that impacting health and what can be done about that?
All right, I'm sorry, Elizabeth, it was a little bit long.
Okay.
I'm going to ask the first part. Je crois que ma question, certainement, elle a déjà été, il y a déjà eu une réponse à ma question, mais je vais la poser quand même. Peut-être il y aura une différente réponse. Comment est-ce que le racisme se passe, comment est-ce que ça se passe au Congo? Quelle est la situation du racisme au Congo entre eux-mêmes, le peuple congolais? Et ça, c'est la première partie de la question. And Elizabeth, what was the second part of the question about this disproportionate?
Is it disproportionately affecting certain populations and their health?
Est-ce que le racisme au Congo affecte des populations différentes d'une façon disproportionnée et comment est-ce que ça affecte leur santé?
Thank you.
Le racisme, j'ai dit que le racisme a engendré beaucoup de problèmes et partout ailleurs dans les sols congolais. Tout ce que nous rencontrons, la guerre qui est dans la population, la crise, c'est lié au racisme. Donc, il y a la manque de considération de la population, puisque celui-ci est de telle tribu, celui-ci est de telle race, et ainsi de suite. Donc, c'est ce qui a paralysé tous les systèmes.
Un moment, docteur.
Wait.
No, c'est bon. I'm good, thanks. All right, so as I was saying, racism has really cultivated or has really unleashed a lot of problems in the Congo. And I was talking about a lot of tribal conflicts that were related to racism as well. First, the lack of consideration between tribes and race. Allez-y.
Oui, c'est ce que j'ai dit, que le racisme au sol congolais a entraîné même la prolifération de plusieurs partis politiques, puisque celui-ci est de tel, celui-ci est de tel. C'est ce qui a fait que plusieurs partis politiques ont entraîné beaucoup de combats et beaucoup de conflits.
So another thing about racism is that it led to the development of many political parties in a very in a very disorganized way. So because one person is from this region, the other person is from this region, therefore the need to create political parties.
Okay. Pastor Boyamba, would you please respond as well? You've done a lot of work, Reverend Boyamba, a lot of work on reconciliation. I'm going to ask him to come in. Pastor Boyamba, il faut effectuer votre micro.
Vous avez fait beaucoup de travail dans le domaine de réconciliation. Avez-vous autre chose à ajouter?
Oui, je voulais ajouter sur les guerres, ce que l'Église aurait fait.
Okay. I wanted to add about concerning war, what the church could have done.
Surtout la guerre de 2016-2017.
Pasteur, parlez un peu plus fort, s'il vous plaît.
La guerre de 2016-2017, beaucoup d'enfants ont été traumatisés.
So
Alors,
especially the war of 2016-2017, a lot of children were traumatized.
avec l'équipe de l'SCC, accompagnée de Christy Boyd, nous étions partis à Chimbulu, fief où il y avait beaucoup de guerres.
So
Pour
with the Church of Congo, with the Christian Church of Congo, with Boye, we went to Chimbulu.
Pour nous entretenir avec les enfants qui ont subi le traumatisme, les enfants qui ont vu leurs parents tués, leurs petits frères tués, pour travailler avec eux, soulager un peu leur mentalité, pour les amener à penser et à voir la vie autrement.
So we did some work with the children. We had to try to take care of them mentally. The children who had been traumatized due to seeing their parents, their siblings being killed. So we had to try to work with them mentally.
Et nous avons fait ce travail-là. Les enfants ont été soulagés et il y a une équipe d'enseignants qui est là en permanence.
So the children received our help, and there is a team currently there that has been settled there, that is currently working with them permanently.
Et même au niveau de Kananga, nous avons organisé les enseignements auprès des jeunes qui ont participé dans les combats.
And even in Kananga, we organized some training among youth who were part of the armed conflicts.
Pour enseigner la culture de la paix dans la société.
To teach them about peace and to be able to integrate themselves in the society. So to cultivate peace.
Et il y a eu même des jeunes gens qui ont témoigné qu'ils ont participé à la guerre et ils auraient même tué certaines personnes, mais on gardait ça en confidence.
Some youth actually testified. They revealed that they participated in those armed conflicts and they could have killed some people, but we kept that information confidential.
Et on priait toujours pour eux pour les intégrer dans la vie de l'Église.
And we kept praying for them so that they can become an integral part of the church.
Et pour ce qui est du racisme, l'essence du racisme, ce n'est pas au Congo, nous c'est le tribalisme.
So concerning racism, the sense itself of racism, it's not really in the Congo. Our issue is tribalism.
Et personnellement, je remarque que nous vivons bien avec l'étranger qu'avec les compatriotes congolais.
I noticed that we actually dwell or live better with a foreigner rather than a fellow Congolese citizen.
Ce qui nous dérange plus, c'est le tribalisme et le clanisme au Congo qui détruit toute notre vie communautaire.
So what is the real issue in the Congo is tribalism, and that's really what's destroying us. Thank you.
Thank you. I just will remind you that the 2 sessions in November will be dealing with the question of racism and tribalism from a theological perspective. Dr. Kabwe Mbala from Ndesha from the university there, and Elsie McKee, grew up in the Congo, and Pastor Boyamba himself and others will be discussing that issue.
Juste pour faire un résumé, notre session au mois de novembre va vraiment parler en profondeur du thème de racisme et de tribalisme sous la perspective théologique.
Okay. Now I'm going to call on Roberta to ask her question.
Hi, my name is Roberta Spalding, and I have a question for Dr. Serge. I know that when the conflict started, many of the interns and other medical personnel at IMCK fled because they felt like they were in danger. And I wonder if the interns have returned, the nursing students, and if the people who were in tribal groups that felt they were afraid, if they feel secure enough now to have returned to train at IMCK.
Ok, je vais un peu résumer la question, mais je m'appelle Roberta Spalding et ma question est pour le docteur Serge. Ma question est, je comprends que quand les conflits avaient commencé, beaucoup d'internes et le personnel médical devait fuir. Et j'aimerais savoir s'ils sont revenus, les infirmières, les internes, s'ils sont revenus.
Thank you very much, Roberta Spalding. It's a very good question. During the conflict of Kamwena Sapo, it was very, very difficult to run IMCK. But according to the education system, our 2 nursing schools didn't close because many militians were from our county, from Nganza County, so that except our nursing schools.
Un moment pour traduction.
Oui, Dr. Ocho, tu peux?
Procéder.
Yeah, thank you. Yeah.
Dr. Ocho, tu peux?
During the conflict of Kamwena Sapo, Dina, can you follow me?
Yeah, I was asking Dr. Joy if he could go, but I'll go ahead.
Okay.
Go ahead.
Durant le conflit de Kamwena Sapo, nos 2 institutions de formation médicale n'ont pas fermé parce que certains de militants engagés dans la guerre étaient de notre localité.
And also some of militian men were our students.
Et certains des miliciens étaient nos étudiants.
So that all classes were closed except our 2 nursing schools. That's about school department.
Toutes les autres sections étaient fermées à l'exception de nos 2 classes de section infirmières qui étaient restées fonctionnelles.
And now talking about the health department, our hospital, the Good Shepherd Hospital, was open, but it was very difficult. I must admit that we were functioning difficultly.
Concernant notre département de santé, notre direction de l'hôpital Bon-Berger était opérationnel, mais le fonctionnement n'était pas aussi aisé.
Yeah, I must thank Dr. Fletcher because he stayed in Chikaji and he was the only one surgeon for our province.
Je dois remercier ici Dr. Fletcher qui, lui, est resté à Chikaji et il était notre seul chirurgien.
And he was asking for my help to come and work with him.
Il avait demandé mon assistance pour que j'aille le rejoindre et travailler ensemble avec lui.
And it wasn't easy for me because I had to reach Chikaji from the downtown Kananga.
Ce n'était pas vraiment facile pour moi parce que je devais rejoindre Chikaji en partant du centre-ville de Kananga.
And there were many obstacles, many difficulties from Kananga to Chikaji.
Il y avait beaucoup de difficultés et beaucoup de dangers sur la route Kananga-Chikaji.
There were many militias and soldier barriers, obstacles.
il y avait de la milice et les barrières militaires sur les tronçons.
And according to the internship students from Kinshasa, especially from UPC,
Concernant le stagiaire ou les internes dans notre institut de formation à Kinshasa,
they were with us in Good Shepherd Hospital.
pendant cette période, ils étaient avec nous dans notre centre Bon Berger.
It wasn't possible for them to travel from Kananga to Kinshasa.
Il n'était pas possible pour eux de quitter Kananga pour entrer à Kinshasa.
And after the Kamwina Sapu situation, they went back to Kinshasa because their parents were very afraid of the trouble.
Après le conflit Kamwena Sapu, ils étaient obligés de rentrer à Kinshasa parce que leurs parents étaient très effrayés par le conflit.
Meanwhile, we stayed only with the local student university of Kasai.
Pendant ce temps, nous sommes restés simplement avec les étudiants locaux de l'université du Kasaï.
And according to the internship, especially for students from Kinshasa, everything was stopped.
En ce qui concerne les stages, pour les étudiants de Kinshasa, venus de Kinshasa, tout était à l'arrêt.
But for the moment, everything is reopened, and we had one of a generation of UPC students. They finished the internship study last 2 months ago. They went in Kinshasa. We are waiting for the next promotion of UPC student for internship.
Pour le moment, tout a réouvert et nous avons complété une génération, une promotion des stagiaires de l'Université protestante de Kinshasa, l'Université protestante du Congo, et nous attendons une deuxième génération.
Et pour le moment, nous attendons. Ils viennent d'être délibérés par rapport à leur jury. On a délibéré il y a 3 jours, donc bientôt là, l'autre génération, l'autre promotion viendra d'un moment à l'autre. Merci.
The current generation of the student has concluded. They will have their final grade soon, in 3 days, and we will be waiting for the next generation to come, or next group of
Be to
students.
God. Thanks be to God.
Nous remercions le Seigneur. Dieu soit loué.
Okay, the next question comes from Dan Metzel. Dan Metzel, une question à poser.
I'm passing on a question which came up in a conversation between my brother John Chimangwa Mukindola and Alexis Kayembe, the infrastructure advisor to President Tshisekedi.
Ma question est d'une conversation que j'ai eue entre mon frère John et Alex, qui est un des conseillers du président Tshisekedi.
The question is this: does CPC have a plan for electrification of the mission stations? My brother had asked him about Luandai, if the government could help with that, and he gave the impression he wants to help with the larger system.
Ma question est sur l'électrification. D'après nos discussions, nos entretiens, il y a un projet de travail sur Lubondai. Est-ce qu'il y a quelques précisions à ce sujet?
And I should add, how can the U.S. church help with such a project?
Je pourrais aussi ajouter comment est-ce que les États-Unis peuvent aider dans ce projet.
Who is the question addressed to?
À qui est-ce que la question est adressée?
Well, I think first of all to administration at CPC. I don't know who can help, but perhaps Reverend Buyamba.
J'adresse la question à l'administration de CPC. Peut-être Pasteur Mbuyamba peut aider avec la réponse.
Le Bondaï, comment les États-Unis peuvent nous aider? Je crois que pour mieux nous aider, il faut envoyer une équipe qui peut faire l'expertise de voir le lieu, parce que nous avions un grand problème d'abord de l'eau. De l'eau, c'était un peu résolu, mais pour le barrage, je crois que le fils de John Metzel a tenté à plusieurs reprises.
Pasteur, pouvez-vous y aller un peu en section?
Pardon?
Aller section par section pour permettre la traduction.
Merci beaucoup, merci. Je dis que les États-Unis peuvent envoyer une équipe faire l'expertise, examiner le milieu.
All right, so what I will say is to better help, the first thing is the US can actually send a team of experts to inspect the place, to inspect the place. And the first thing is we had a water problem, which was sort of resolved.
Parce que pour l'électrification, le jeune John Metzel, il a essayé, mais ça n'a pas abouti.
For concerning electricity, the young John Metzel tried, but it didn't lead to anything. There was no positive outcome.
He's talking about the hydroelectric dam at Lubondai.
I should say that the question is larger, though. It's a question about the whole CPC system, the mission stations. Is there a larger plan? Because the Congolese government apparently is interested in helping the entire system, not just the Bondi.
La question est un peu plus large que seulement le projet de Lubondai, parce que le gouvernement congolais avait décidé d'intervenir pour l'ensemble du projet afin d'aider le peuple du Kasaï, pas seulement la CPC.
Or at least they're interested.
Oui,
si certainement ils sont intéressés.
Mais cet aspect-là du gouvernement, je n'ai pas de renseignements. On peut étudier peut-être dans la prochaine session, nous pouvons partager.
That aspect regarding the government, honestly, I don't have any information. Maybe we can study that and have more answer in the next session.
I wonder if Dr. Nosy has anything to add, since he was working on a larger project in Bukavu.
Est-ce que Dr. Messi peut aussi aider parce qu'il a travaillé sur un projet plus ou moins large à Bukavu?
Est-ce que Dr. Nosy est là?
Is Dr. Nosy there?
Je suis là.
Okay.
First, I had to unmute me. Sorry.
Yes, thank you.
Je devais d'abord me démuter. Pardon pour cela.
Right. So I don't know if I should really answer in French or English, but
je ne sais pas si je dois parler en français ou en anglais. Sentez-vous libre.
Je vais le faire en français et traduirai en anglais peut-être.
That's good. Go ahead in French and we'll translate here.
Okay, I wanted to give a break to the translators, but that's fine.
Oh, you're fine.
So I don't know if it's going to be very helpful, but what we are doing in the Kivu is mostly a feasibility study based on The larger framework of this is that actually we are looking at helping our local partners to generate clean, affordable, and viable source of energy, mostly solar energy. So we are not speaking about hydroelectric. So I would stop here and then I will continue so you can talk.
Nous regardons à plusieurs façons de travailler, pas seulement les courants hydrauliques, mais les autres moyens de génération d'électricité.
Okay.
Dr. Netty?
While you're there, Dr. Gloria has a question for you as well.
Pendant que vous êtes là, notre docteur a une question pour vous aussi.
Gloria, you want to ask your question, please?
Docteur Gloria, pouvez-vous poser votre question?
I'm sorry, did you hear me?
Yeah, we're waiting for the question to come to you.
First,
Gloria, you're unmuted. You can go ahead and talk.
Okay. So the main thing is really that we are doing a feasibility study.
Yeah, no, there's a new question for you, Doctor.
So, okay, so let me drop this one. And where is the question?
Okay, the question is coming. Gloria, please ask your question.
Gloria, priez de poser votre question.
Okay, I will read her question. My name is Gloria, a young Congolese with a passion for global health equity. I'm currently doing my master's studies in global health delivery outside the country. And my plan is to go back to my country and put into practice the skills I learned from this program. Thus, I would like to get more information about different international national health institutions already there in the DRC.
Well, en résumé, donc je suis Gloria, je suis une formation et je me demande comment je peux être utile d'après les informations reçues jusque-là et quelles sont les autres informations supplémentaires qui peuvent m'aider à m'engager.
Ok, j'aimerais peut-être attirer l'attention de Gloria.
I'd like to get Gloria's attention
sur un site que je vais mettre dans le chat.
And I'm going to put the link to a website in the chat.
It is a program for young people who are either starting or mid-career.
C'est un programme pour les jeunes qui commencent leur carrière ou sont au milieu de leur carrière.
Et c'est un programme sur Global Health Equity Leadership.
It's a program on the global leadership, global health leadership equity.
Oui, ce programme il y en a 7 qui ont été subventionnés par une organisation qui s'appelle Atlantic Philanthropies.
There were 7 that were subsidized by an organization called Atlantic Philanthropies.
Et il y a un de ces 7 programmes a maintenant une ouverture, une ouverture d'enregistrement pour des candidats.
One of the 7 has an opening. You can actually apply. It's looking for candidates.
Des candidats intéressés à suivre ce programme pour 1 an.
It's looking for candidates interested in following this program for 1 year.
Les candidats peuvent se trouver n'importe où dans le monde.
And candidates can be living anywhere in the world.
Mais ce programme est donné par GW, it's actually George Washington University.
And this program is offered by George Washington University.
C'est un programme qui est localisé dans un département qui est le Fitzhugh-Mullen Institute.
And that department is located in Fitzhugh Institute.
Oui, et je cherche pour l'instant rapidement le site pour vous l'envoyer.
And bear with me, I'm quickly looking for it.
Ce sont des cours ou des discussions qui sont mentored, comment dit-on, qui sont produites sous la supervision de gens expérimentés. Ça se donne en ligne.
It's courses or discussions that are mentored under the supervision of experts, and it's given online.
Oui, et avec des rotations qui sont en présentiel, donc en face-to-face.
So you do have some face-to-face rotation.
Qui se font dans des projets liés à Global Health Equity, que ce soit en Afrique, aux États-Unis ou en Asie du Sud-Est.
So those are projects related to global health equity, and they're located in the US, Asia, Africa.
Oui, et le concept est que les participants travaillent en team.
So the concept is for participants to work in teams.
Avec les gens constituant un team en généralement des disciplines diverses.
With people, with participants having some diverse from different backgrounds.
Mais voilà, je vais trouver le site ici, je vais vous l'envoyer.
And here is the website. I'll send it in a few moments.
Et si vous voulez plus d'informations, vous pouvez toujours m'envoyer un email. Les organisateurs peuvent vous donner.
And for more info, you can send me an email. You can get those from the organizers.
That's it. Let me put it in here.
Thank you again. Merci beaucoup. We have a question now from I'm sorry, Martina Manmock.
Merci encore une fois de plus. Nous avons une question venant de Martina.
Martina, are you there? Do you have
Yes.
like to ask your question, please?
Yes, I have a question. Thank you so much. Yes, my question is this. The population in the DRC is usually poor and they pay by the system of out-of-pocket.
La population au Congo est généralement pauvre et ils payent à travers le système de leur disponibilité en poche.
Yes, then I would like to know what is the scheme that the Americans implement in the Congo to help the poor people have access to healthcare services.
J'aimerais un peu savoir quel est le mécanisme par lequel les États-Unis aimeraient aider le peuple congolais à avoir accès aux soins de santé.
Bill Rule, do you want to take a whack at that one?
Bill, pouvez-vous essayer de prendre cette question?
Well, I don't know that I can give an authoritative answer.
Je ne sais pas, je ne peux pas avoir une bonne réponse à cette question.
if you are suggesting that the Americans should put in place an insurance scheme in Congo. I don't think I've heard of any such thing.
Si par cette question, vous suggérez que les Américains doivent prévoir une sorte d'assurance médicale, je doute fort que cela soit possible.
That is something that the Congolese government should do, perhaps with some advice from countries which have already done it.
Cela est une question que le gouvernement congolais doit prendre en charge, certainement peut-être avec les conseils ou la consultation de ceux qui ont déjà mis cela en place ailleurs.
However, if your question is whether Americans, for example, the churches here in the United States should be sending money to pay for the health care of Congolese, then that is something that is done on a small scale.
Votre question, c'est peut-être savoir si le peuple américain ici, ou spécialement les églises américaines, peuvent mettre de côté un fonds pour assurer les soins de santé des Congolais. Je peux vous dire que cela a été fait à un niveau très faible.
I think that Dr. Serge can answer on the question of the fund which they try to maintain at IMCK for paying for indigent patients.
Je pense que Dr. Serge peut prendre la partie de la question sur les fonds qu'il gère pour le paiement de soins de quelques-uns.
Thank you, Bill. Thank you for this question. As Bill said, American people are helping Congolese people.
Comme Bill a dit, les Américains sont en train d'aider les gens.
In various aspects.
Dans des aspects différents.
Talking especially for how American people can help about out of pocket of Congolese people, I can say this.
Spécialement la question concernant comment les Américains peuvent aider les gens qui payent individuellement par eux-mêmes. Je peux dire ceci.
The good solution, as Bill said, is that the Congolese, the DRC government must take his responsibility in medical insurance, as we can see in other countries.
La bonne solution est que le gouvernement congolais doit prendre cette responsabilité en assurant les soins de santé, en assurant les paiements pour les soins de santé comme les autres pays l'ont fait ou le font.
But about the contribution of American people, I can take many examples.
Concernant la contribution des Américains, je peux présenter plusieurs exemples.
Generally, American people, according the various aspects, are contributing to pay the patient health care bills.
Généralement, les Américains contribuent à payer les soins de santé, à payer les soins de santé de la population.
And as Martina said, the population is very poor. And when...
Et comme Martine l'a dit, la population est très pauvre.
And there are many funds sent from USA to IMCK like funds from MBF, the Medical Benevolence Foundation.
Et il y a beaucoup de fonds qui sont envoyés par les Américains à AMCK à partir de MBF.
Yeah, we receive funds for indigent patients.
Donc, nous recevons les fonds pour les patients des populations des indigènes.
Yes.
Des indigènes.
Yeah, sure. And also we received funds from the project called OFDA.
Et aussi, nous avons reçu des fonds d'un projet qui s'appelle OFDA.
Yeah, to support indigent patients.
Pour supporter les patients les populations indigènes.
We receive also funds from individual people from USA.
Et nous recevons aussi des fonds des Américains eux-mêmes, des individus.
They can apologize me because the list is not exhaustive. If I can begin now, I can take 1 year to spell and to cite everyone. It will not be possible.
Excusez-moi, mais la liste est longue. Si je devais dire le nom de tout le monde, ça pourrait nous prendre 1 an.
Yeah, I think the host of this virtual conference and other people, they themselves know that.
Je crois que les hosts de cette conférence peuvent informer les gens eux-mêmes directement.
Yeah, I think in short, we receive funds directly from American people or through many and various projects for indigent people.
Donc, en bref, je peux dire que nous recevons des fonds du peuple américain eux-mêmes directement ou à partir d'autres projets ou des organisations.
Thank you.
Merci.
Thank you. Merci beaucoup. I have a question for Dr. Conde. We've talked a good deal about the issues of race and tribalism and so forth in the Congo, and you had a very excellent presentation on the questions of access to the United States.
Dr. Joe?
I said,
Dr. Joe?
Dr. Conde had a very nice presentation on access to healthcare in the United States.
Dr. Conde a eu une très bonne présentation sur l'accès aux soins de santé.
And my question then is to those of us on this in the United States now, how can
à ceux qui sont avec moi ici aux États-Unis,
we who've had some experience internationally with our connections with Congo, how can we better address the inequalities in the United States, given that background, that foundation?
Pour nous qui avons eu une expérience internationale dans notre connexion avec les Congolais, comment pouvons-nous profiter de ces expériences pour adresser la question de l'inégalité?
Merci pour la question. Mais si je la comprends bien, vous voulez savoir comment nous pouvons travailler pour faire face aux inégalités aux États-Unis ou au Congo?
Oui, nous parlons des expériences communes entre les États-Unis et le Congo et nous voulons élargir un peu la question. Qu'est-ce que nous pouvons profiter de la formation que nous avons eue au Congo pour travailler ainsi aux États-Unis?
We want to expand on the question and just try to figure out how can we use that international experience to apply it here in the US.
Oh oui, je comprends mieux maintenant.
I understand better now.
Oui, oui. Eh bien, je crois que cela nous ramène aux réponses qui ont été données par le docteur Neusi
That brings us back to the answers that have been given to by Dr. Nerzi.
Oui, parce que il y a des possibilités de formation aux États-Unis, mais elles sont très, dans un sens, elles sont très strictes parce que elles sont très souvent offertes par des universités ou des organisations qui ont des systèmes bien déterminés pour recevoir des postulants pour travailler avec eux.
There are possibilities in the US, but these opportunities are very strict and they are offered by a university and organizations. And I'm sorry, continue. You said, pardon, allez-y.
Pour recevoir les demandes des postulants pour travailler avec eux.
To receive application from participants to work with them.
Oui, je crois que la réponse n'est pas complète et peut-être qu'elle ne répond pas à ce à quoi vous vous attendez.
I believe that the answer is not complete and it doesn't really meet your expectation, or it doesn't really answer to your expectations.
It's a good start. Thank you. We appreciate your input.
C'est déjà un bon début, merci. Merci pour votre addition.
Merci.
OK. Est-ce qu'il y a une autre question? Is there another question that I am missing?
Yes, Jose wants to pose a question.
Okay. Jose?
Monsieur José a une question.
My question is this: given the level of poverty and the fact that many people go to traditional healers for medical treatment or for medical issues, is there any integration, interaction, engagement with the traditional healers and the modern establishment?
Vu le niveau de pauvreté qu'il y a au Congo et aussi cette habitude d'aller voir des médecins traditionnels, est-ce qu'il y a une interaction ou une coopération, partenariat entre ces médecins traditionnels et la médecine moderne?
Jose, did you have someone in mind to answer your question?
José, avez-vous quelqu'un à qui vous aimeriez poser cette question particulièrement?
Any of the presenters, because it deals public health and hospitalization, etc.
La question est vraiment pour tout le monde, tous les gens. C'est une question qui concerne la santé publique, le domaine de médecine, à n'importe qui.
Okay, we'll go back to Dr. Serge then.
Yeah, thank you. Yeah, thank you, Jose. That's a good and a great question, because nowadays there are many traditional healers.
Merci beaucoup, José, pour votre question. Maintenant, de nos jours, ici, il y a beaucoup de médecins traditionnels.
Yeah, there is a fact, traditional medicine has now a coordination in our country.
La médecine traditionnelle, le fait est que la médecine traditionnelle maintenant a une sorte de coordination dans notre pays.
And there is a collaboration. This medicine, this traditional medicine, is integrated in our health care system.
Et il y a une collaboration, donc cette médecine traditionnelle est intégrée dans notre système de santé en général.
And as Jose said, there are many people when they are healed going to see traditional healers, and sometimes we have data which escape to the health care system of DRC.
Comme José l'a dit, quand Joseph l'a dit, il y a beaucoup de gens, quand ils sont malades, ils partent chez des médecins traditionnels et il y a beaucoup d'informations, il y a beaucoup de cas, il y a beaucoup de données qui échappent notre système de santé.
Therefore, the DRC healthcare system think to integrate this traditional medicine to let people even they can go to traditional medicine, but they might be integrated in our health system data.
Donc, le système de santé congolais permet d'intégrer, à intégrer cette médecine traditionnelle, mais veut que quand les gens partent voir ou utilisent cette médecine traditionnelle, ils veulent que ces informations, ces données soient intégrées dans le système de santé.
And the majority of these traditional healers are registered to the coordination of traditional medicine.
Et la majorité de ces soignants, de ces médecins traditionnels sont enregistrés dans le système de santé congolais.
But there are also many traditional healers which are not integrated, so that there are many that we can not are under notified in the healthcare system. That's the reality. I think it's not only for DRC, but for subtropical countries in the world.
Et il y a beaucoup de ces médecins traditionnels qui ne sont pas intégrés et beaucoup de données échappent notre base de données. Et c'est le cas déjà, de toute façon, c'est le cas dans beaucoup d'autres pays tropicaux.
This is my contribution.
Et voilà ma réponse.
Thank you very much. Merci beaucoup, Dr. Serge. Thank you, Jose. And I think I'm not seeing other questions coming up.
I have a question for Dr. Nursi.
Okay.
You made a great point that most of the lifespan is influenced by factors in the community outside of the hospitals.
Ma question est pour Dr. Nursi. Vous avez mentionné un bon point. Vous avez dit que la vie d'une personne est influencée par d'autres facteurs qui sont des facteurs communautaires.
And you said, you seemed to suggest we should move our funding donations away from hospitals and into more support of community needs. Can you elaborate on that?
Et vous avez suggéré que la plupart les fonds qui sont envoyés, vous avez suggéré qu'ils soient enlevés des hôpitaux et qu'ils soient qui se dirigent vers les besoins de la communauté. Est-ce que vous pouvez plus élaborer sur ce point?
Yes, yes, Bill. Let's tackle first the social determinants of health that Dr. Kanda mentioned earlier in her presentation. It is true
Parlons d'abord des déterminants sociaux de santé que Dr. Kanda a mentionné dans sa présentation.
As I indicated briefly, if you were to look at the longevity of around the 20th century, at the turn of the 20th century.
Si vous regardez la longévité du 20e siècle, au début du 20e siècle,
of the population, right?
De la population.
The average span was around 40 years.
La
And,
moyenne était pratiquement à 40 ans.
and in less than a century, it has almost doubled.
Et en moins d'un siècle, cette moyenne a pratiquement doublé.
And the question was really, well, the big issue was really what are the elements responsible for this?
Et la question vraiment est quels sont les éléments qui sont responsables pour ce changement?
And there were a few commissions that looked at this, and one was at the Academy of Science, the late the Institute of Medicine.
Quelques comités ont regardé, ont fait des recherches sur ça, et une c'était the Academy of Science, l'Académie de sciences.
And it turns out that actually 90% of this incredible increase in the longevity is due not to biomedical reasons.
Et il se fait que la plupart, 90% de cette augmentation de longévité de vie ne sont pas dus aux facteurs biomédicaux.
It's not because you have a better diagnostic capacity and so on, better drugs.
Et ce n'est pas parce qu'on a des bons médicaments maintenant, des meilleurs médicaments ou des meilleurs appareils, des tests de dépistage.
These are very important, but it only accounts for 10 to 15% of this longevity.
Certes, elles sont très importantes, mais ça joue seulement à 10%. Ça contribue seulement à 10% de cette augmentation de longévité.
So where are those 90%?
Et du coup, où sont ces 90%?
And actually, that's really what we are referring to, the social determinants of health. We could really elaborate as a larger determinants of health, not only social, but economic, cultural.
Et c'est comme ça qu'on dit que ces 90% sont attribués aux déterminants sociaux de santé. Et il n'y a pas que ça, on peut élargir cela. Ça peut inclure aussi l'économie, le domaine économique.
To a certain extent, social determinant is a misnomer.
Et du coup, les déterminants sociaux ça ne définit pas très bien ce qui se passe.
It is really a much larger issue, as I mentioned. It's really not only where you were born, where you live, what you do, what is your biomedical makeup, if you want, your genetic makeup, and so on and so forth. But there are those.
Le problème, il est plus large. Il est plus large. Ce n'est pas seulement là où vous êtes né, là où vous habitez, vos gènes. C'est plus large.
So now let's be concrete.
I'm sorry?
Now let's be concrete.
Donc, soyons concrets, soyons vrais.
What I mean by this, and that's really why the tie with your question about health system comes into place.
Et c'est vraiment de ça que je parle et ça répond à votre question concernant le système de santé.
Because if we speak about health, we are not speaking about medical health.
Si nous parlons de santé, nous ne parlons pas de la santé médicale.
It is part of it, but it is a small part.
C'est important, mais c'est vraiment une partie, c'est vraiment une petite partie.
So when we look at health systems,
et quand nous regardons le système de santé,
we have invested so much dollars, resources in essentially hospitals, tertiary hospitals, these now more and more larger academic health camps.
Donc, nous avons tellement investi beaucoup de dollars, beaucoup de ressources dans les hôpitaux tertiaires, dans les hôpitaux universitaires aux États-Unis.
But to the detriment of primary care.
Mais au détriment de la santé primaire, de la santé générale.
And when we speak about healthcare, primary care, it is also a misnomer.
Et quand nous parlons de la santé générale, la santé primaire, ce n'est pas aussi une bonne définition.
Because when we speak about primary care, we are talking about a coordinated and integrated approach where you bring these various social determinants of health in the services, in the service provision.
I'm sorry, can you repeat that?
Yes. So I'm saying that actually when we speak about primary health care, what we are talking literally, or what we should be talking, is really about integrated approach and coordinated approach of the social determinants in the service provision. That doesn't include only medical care, it's a social care. So this is really the major issue that we are facing now. And I will give you a very concrete example.
Donc, quand nous parlons vraiment de la santé primaire, c'est une approche qui est coordonnée, qui est intégrée dans les déterminants, les déterminants sociaux de santé. Et c'est un service de provisionnement qui n'est pas seulement, and that's where I stopped.
So in other words, to make it simple, it's really that you need really to have really a holistic approach to health. And that is really not only limited to medical care. Okay, so we are, public health is important. Social care is important. Earlier, someone asked about global health and global health or health equity. And I want really to make a point about this. Health equity will not really happen unless you have social equity. And that is an important point because it will define, and it is defining now, the future of our health system. And it is not only in the US.
That was very long.
I'm sorry. So maybe I can say it in French.
Yes, go ahead.
Okay, all right. So let me try my French here. Si nous regardons le futur des systèmes de santé, pas uniquement aux États-Unis, mais aussi bien en DRC qu'en Inde, que dans d'autres pays, la tendance maintenant est de rediriger les ressources vers des services intégrés au niveau des communautés, ce qu'on appelle la santé primaire, dont nous parlions il y a une minute. Le retour sur l'investissement, il y a pas mal d'études qui ont été faites sur des différents scénarios, mais le retour sur l'investissement est absolument énorme. I'm just changing this in English because that's the point I wanted to make, is that there are some scenarios that have been looked at this and looking at the return on investment, which is really absolutely remarkable. And maybe the last point I want to make, Bill, because it's really too long, is that actually we are really looking through the wrong lens when we speak about putting money into a health system. One of our Congolese friends mentioned what happened when Americans leave the Congo. Then things go down. Vous voulez traduire ou je veux traduire?
No, allez-y.
I think it's, go ahead, Dina.
So anyway, the main point being that actually we are talking about sustainability and we are looking at funding through a wrong lens. We are looking at this like humanitarian aid. This is investment, but we need to redirect the investment so that it becomes sustainable in the country.
Yeah.
That's my point. I'm sorry, it's a long-winded answer.
Go ahead, Dina. Translate that.
Okay, I got part of it. Actually, Dr. Joe, do you have some part of it?
Yes, I was saying, je disais que
Thank you.
Un de nos collègues congolais a fait une remarque qui m'est restée dans l'oreille, c'est que lorsque les Américains dont je suis viennent au Congo, une fois qu'ils partent, les choses ne continuent pas. Et donc, c'est un problème lié à la sustainability, comme on dit en français.
Durabilité.
C'est ça, la pérennité.
La durabilité.
I think Dr. Kanda asked to comment on this.
Good.
Yes.
So anyhow, that I think it's a good point, because what we need to think about, ce que nous devons penser, c'est comment les dollars qui sont investis dans le système congolais puissent perdurer. Sorry for speaking so long.
And I believe Dr. Konda has another comment on that.
Oui. Shall I speak in French or in English? What is the most practical way?
Either way.
Speak in French and then we'll translate.
Yes. Or let me speak in English, because your French is so good. You may get the nuances better than I will. So I am in great agreement with Dr. Nursey.
Je suis totalement d'accord avec Dr. Nursey.
And the perspective that he presents, the holistic perspective that he presents,
son opinion, tout ce qu'il a présenté, cette perspective entière.
And I am also very much in support of his contextual perspective.
Et je supporte vraiment sa perspective.
Oui.
Sa prospective, le contexte, sa perspective, le contexte dans lequel il a présenté.
Oui, parce que le contexte aux États-Unis n'est pas toujours le contexte au Congo.
The context in the US is not always the same in the Congo.
And I wanted to share a personal experience on the issue of health investment.
Et j'aimerais partager une expérience personnelle sur le sujet des ressources sur la santé.
When my husband, Louis, who is Congolese, and
Quand mon mari Louis, qui est congolais,
il est chirurgien cardiaque.
He is a cardiac surgeon.
Quand nous sommes venus au Congo pour assister Dikembe Mutombo,
when we came to the Congo to help Dikembe Mutombo,
dans le développement d'un hôpital à Kinshasa,
to pretty much develop the hospital in Kinshasa,
nous avons fait face à ce dilemme.
We faced this dilemma.
Parce que nous avons vu beaucoup de situations. Oh, I'm speaking French now.
So we witnessed a lot of situations. We saw a lot of situations.
Là où les gens mouraient à cause de problèmes qui étaient facilement corrigeables aux États-Unis.
And people were dying because of problems that were easily resolved in the US, that were easily addressed in the US.
Par exemple, nous avons vu des patients qui avaient une appendicite.
For example, we saw a patient with an appendicitis.
Mais parce qu'il n'y avait pas de chirurgien, ces patients mouraient.
But due to lack of surgeon, the patients will die.
Donc, nous sommes venus à la conclusion qu'il faut balancer les deux. Il faut balancer absolument la prévention d'abord.
So we came to the conclusion that we must balance both. Starting with prevention.
Et aussi faire face aux problèmes urgents qui existent.
And face the urgent problems that exist.
Et maintenant, nous avons un programme sur le cancer du col.
So now we have a program concerning cervical cancer.
Notre but ultime est de faire de la prévention et de donner des vaccins contre le virus HPV.
So our ultimate goal is to work toward prevention and give a vaccine, HPV vaccine.
Mais en attendant, nous avons dépisté plus de 20 000 femmes qui ont le cancer du col.
But in the meantime, we only screen about 20,000 women who have cervical cancer.
Notre réponse est que nous avons des partenaires qui viennent de plusieurs pays et qui nous aident à développer le traitement nécessaire pour ces femmes.
So our response or our solution is to work with partners, international partners, that can help us develop treatment for these women.
Donc, c'est là où nous sommes maintenant. Nous sommes en train de soigner ces femmes et de continuer le dépistage et de faire de la prévention en même temps. Et
So this is where we are right now. We are treating these women and working toward screening to prevent cervical cancer among these women.
Et nous voulons aussi trouver des ressources pour acquérir le vaccin qui est cher, que les femmes ne peuvent pas se payer elles-mêmes.
So we also want to find resources to actually treat these women, because the treatment is very costly and they cannot afford it themselves.
Yes. So, finalement, en conclusion, je pense que l'univers est grand et qu'il nous faut tout faire en même temps.
So in conclusion, I'll say the universe is big and we have to do everything at the same time.
Merci.
Thank you.
Okay, thank you for that very fine discussion and much to think about. We're going to take one last question from Paul Williams, briefly to Dr. Serge.
Et nous allons prendre une question de Dr. Paul et ça sera à Dr. Serge. Elle est dirigée vers Dr. Serge.
Oh, thank you very much. I would like to make a brief comment about the issue that Jose raised related to traditional healers and their integration into the healthcare system. During the 9th Ebola outbreak in the Equator province in 2018, I was able to visit not only in Bikoro, but also Itipo, the epicenter of the outbreak. And we discovered, as I was conducting interviews, that there was a 5-month delay from the first victim of Ebola.
Give the translator a chance.
Okay, yes, please.
Dr. Gervasi. All right. I'm sorry, go ahead. You said from the 9th Ebola outbreak?
During the 9th Ebola outbreak, we observed that part of the delay in recognition by the Ministry of Health and OMS or WHO that there was an epidemic outbreak was due to a lack of trust between healthcare professionals and traditional healers.
Pendant la 9e épidémie de l'Ebola, on a remarqué qu'il y avait un retard de rapport des cas. Et c'était dû au fait qu'il y avait un manque de confiance entre les médecins traditionnels et la population.
And critically, I also conducted a small focus group in Kinshasa with both pastors and doctors. And
Et j'avais aussi fait un groupe de focus entre les médecins et les pasteurs des églises à Kinshasa.
And it was very revealing that the pastors in the focus group were very open to conversation with traditional healers, but the physicians were not.
Et on a remarqué que pendant ce groupe de focus, on a remarqué que les pasteurs étaient vraiment ouverts à parler, à discuter avec les médecins traditionnels, mais les médecins n'étaient pas ouverts, n'étaient pas réceptifs.
So I'm currently working with Dr. Ali Khan and some other scholars in the Midwest, as well as some people in Congo.
Donc maintenant, je travaille avec Dr. Khan et d'autres chercheurs aux États-Unis et au Congo
to develop a syndromic surveillance system that will incorporate traditional healers and local pastors in epidemic response.
Pour développer une sorte de surveillance de syndrome avec I'm sorry, what was the last part?
To develop the syndromic surveillance system to develop a more robust response by incorporating traditional healers and local pastors into a surveillance system.
Et nous travaillons sur un système de surveillance de syndrome pour développer une réponse entre les médecins traditionnels et les pasteurs pour faire des rapports des cas.
And as Dr. Nussi and also Dr. Kanda pointed out, both quite eloquently,
et comme Dr. Nussi et Dr. Kanda nous ont informés,
the social context of healthcare is critical for having a more effective and more robust response to epidemic outbreaks.
Le contexte social est très important pour avoir une réponse efficace pendant une épidémie.
The fundamental problem seems to be trust.
Le problème fondamental, c'est la confiance.
Now, I began with a question for Dr. Serge.
J'ai d'abord commencé avec une question pour le docteur Serge.
And this concerns, in all of this discussion, I have not heard any reference at all to the Église du Christ au Congo and Saint-Louis.
Pendant toute cette conversation, je n'ai pas écouté une référence de l'Église du Christ au Congo et Sanglou.
That was a major part of the conversation last week.
Oh,
yeah.
Okay.
Sorry you missed that. That was the bulk of the conversation last week.
Okay.
C'était une conversation importante la semaine passée. C'était pratiquement la majorité ça a pris la plupart de notre temps la semaine passée.
Well, then I will bracket that question and if I can review the meeting. I was with Mimi Kanda and the Education Congo annual meeting.
J'étais avec Mimi Kanda pendant la réunion d'éducation au Congo.
So I was not able to attend that particular session, but I will check it out. Thank you very much.
Malheureusement, je n'ai pas pu participer à cette session, mais je vais la réécouter. Merci beaucoup.
Dr. Serge, do you have a quick comment, a brief comment? Vous avez un petit commentaire à ajouter là? Nous n'avons plus de temps. C'est fini.
Yeah. Thank you very much, Dr. Paul Williams.
Merci beaucoup, Dr. Paul Williams.
I agree with you in all the lines as you said.
Je suis tout à fait d'accord de tout ce que vous avez dit.
Yeah, and in public health, we speak about, as you know, we speak about 4 delays.
Dans la santé publique, on parle des retards.
Yeah, 4 delays. 4 delays.
Non, 4 retards.
Yeah, 4 delays, as he said. The first delay is that the family decision, when you get ill.
Le premier retard, c'est la décision en famille.
Yeah, people ask themselves is it better to go to the hospital or to be treated by traditional healers.
Les gens se demandent, est-ce que c'est mieux d'aller à l'hôpital ou bien de se faire traiter par un médecin traditionnel?
And in many cases, people choose to go either to the pastor, either to the traditional healer and other opinion leaders.
Dans la plupart des cas, les gens préfèrent aller soit chez leur pasteur, soit chez le médecin traditionnel, ou soit chez une autorité communautaire.
And the second delay is
Et le
the
deuxième retard,
transportation. Yeah, the transportation from the home to the hospital or to the traditional healer, maybe what they can choose.
et le deuxième retard est lié au transport. Donc, le transport, se déplacer de la maison jusqu'à l'hôpital ou de la maison jusqu'à un médecin traditionnel.
The third delay is when the people arrive at the hospital, how many times he can take to be received and treated.
Et le troisième, ça a trait avec quand les gens arrivent à l'hôpital, combien de temps ça prend pour qu'ils soient traités,
And so on.
et etc.
So that I'm very agree with him that we have to integrate the traditional healers, the opinion leaders like pastors and other opinion leaders to avoid many cases which can escape to the healthcare system, the case which are under notified in our healthcare system or in other countries.
Donc, je suis totalement d'accord avec ce qu'il a dit. On doit intégrer tous ces gens, les médecins traditionnels, les autorités des communautés, les pasteurs, pour éviter que les cas soient sous-reportés dans notre système de santé, comme ça peut arriver aussi dans d'autres pays.
And I think to finish, it's a good idea to put all of these opinion leaders together in order to have the possibility to notify more and more cases in our healthcare system. Thank you.
Et donc, pour finir, c'est une bonne idée d'intégrer tous ces leaders, tous ces chefs de communauté pour pouvoir notifier les cas dans notre système de santé.
Okay. Thank you very much. Merci beaucoup à tous. Dans le chat, vous converse, vous allez trouver les données pour les lens pour voir les in the chat. You will find other place. You will find the link to see the previous program, last week's program. Dina, remind people that in the chat they will find where the link for the previous ones.
Et si j'aimerais vous rappeler que sur la fenêtre de converser, vous pouvez retrouver le lien à nos sessions précédentes, donc la session de la semaine passée.
Bill?
Yes, Charlotte.
To everyone, we have tried to answer most of your questions.
À tout le monde, on a essayé de répondre à la majorité de vos questions.
I think only Virgil remains. Virgil?
Il n'y a que Virgil qui reste.
Yes, there was a statement or two made, I think it was by Dr. Kazadi.
Il y avait une déclaration qui avait été faite, je crois, par Dr. Kazadi.
That there were some differences between working in lesser developed countries and the strategies for dealing with the COVID crisis than strategies in more developed countries. And I was curious if he could give some specific examples.
I'm sorry, can you repeat that?
Yeah, specific examples of the strategies that are different in the Congo than in more developed countries.
J'aimerais savoir quelles sont, on a mentionné qu'il y avait des différences donc, en termes stratégie entre les pays en voie de développement et les pays développés. Donc, est-ce que vous pouvez nous dire quelles sont les stratégies qui ont été utilisées?
I would like to say last week, Virgil, you heard Larry, he addressed two. One is more solidarity in Congo on how to wear masks and obey government requests.
J'aimerais dire que Dr. Larry en avait parlé la semaine passée. Il a parlé de deux stratégies. La première, c'était plus de solidarité avec le port du masque. And the second one?
This comes from experience with Ebola.
Et cela vient de son expérience avec le virus Ebola.
Second is contact tracing.
Le deuxième, c'est retracer les points de contact.
There is a good system in Congo after Ebola for contact tracing.
Le Congo a un très bon système depuis la pandémie d'Ebola. Il a un très bon système de retracer les points de contact.
In America, we have a chaotic system for contact tracing.
Aux États-Unis, c'est un chaos total concernant retracer les points de contact.
And if Larry is on, he can comment, or anyone in Congo.
Et je ne sais pas si Larry est là, il peut ajouter quelque chose ou quelqu'un d'autre qui est au Congo.
Yeah, I remember. That's great. Thank you.
Je me rappelle, merci.
Did you want to say anything else, Virgil?
No, that's fine.
Okay.
Aimeriez-vous ajouter quelque chose?
Two good examples.
Good.
Non, merci, des bons exemples.
If I could add one example, you should really look at how Senegal.
J'aimerais ajouter un autre exemple. Vous devez regarder au Sénégal.
How Senegal has handled the epidemic.
Comment le Sénégal a traité la pandémie, l'épidémie.
Yes. It is actually one of the success stories in Africa.
C'est pratiquement une des histoires qui a eu des histoires qui a eu un succès, une des stratégies qui était avancée, qui a réussi.
And as Charlotte said, it was really based on the experience that they gained from the Ebola outbreak.
Et comme Charlotte l'a dit, c'est vraiment une expérience qu'ils ont reçue de la façon dont ils ont traité l'épidémie d'Ebola.
So I encourage people to go and look on the internet.
Donc, je vous encourage à aller chercher sur l'Internet.
Thank you very much. Merci beaucoup. Je crois que nous avons pris un peu beaucoup de temps. We've taken a lot of time, and before we go, we're going to just show you what is coming in November.
Avant de se séparer, j'aimerais vous montrer ce qu'on a prévu pour le mois de novembre.
Our next session will be 2 parts again on November 7th and 14th.
Et on aura 2 sessions, donc 2 parties en 2 tranches, le 7 novembre et le 14 novembre.
The overall theme will be theological reflections on the legacies of racism and ethnic conflict.
Et le thème est intitulé « Réflexions théologiques sur les héritages du racisme et des conflits ethniques ».
We have some excellent presentations coming, beginning with Dr. Elsie McKee and Dr. Kabweyambala Simon.
On a de très bonnes présentations qui sont prévues par le docteur McKee et le docteur Simon.
And then in the following week, we will hear from Pastor Boyamba that you heard just a moment ago, and from the director of our Washington Center, the Washington office of the Presbyterian Church of the United States.
Et la semaine qui suit, on aura une intervention du docteur Bouyamba et aussi du directeur qui travaille à Washington.
The Washington office of the Presbyterian Church.
L'office à Washington de l'Église presbytérienne.
Okay, so we look forward to coming together again in November. And now, if there's something that one wants to say to somebody else, we are going to move to open session.
Et nous avons hâte à vous entendre à se rencontrer au mois de novembre. Et si quelqu'un a d'autres choses à ajouter, la session est ouverte.
Merci beaucoup to Dina and her father.
Oh.
A big thanks to Dina and her father. We agree. Everyone agrees. Another excellent job. Thank you. Thank you. If you would like to speak, please raise your hand and we will try to call on you. Elizabeth Dirk.
Si vous aimeriez parler, levez votre main et on peut vous...
No, I was thank you. Yes, okay. Never mind.
Everyone must unmute themselves, however.
Yes, you will
Looks
need...
like John
Tout le monde, si vous pouvez réactiver votre audio.
Okay, I will say something. I'm actually Elizabeth Warlick Turk, so I grew up in the Congo, but am a missionary in Madagascar. So I'm actually...
J'ai grandi au Congo et aussi j'étais missionnaire en Madagascar.
So most of my time is occupied with Madagascar now, but it just warmed my heart to hear Chiluba. I grew up in Moma, Lubondai, Kananga.
Je passe la plupart de mon temps en Madagascar, mais mon cœur se réjouit quand j'entends parler de Chiluba, j'entends parler de Kananga.
Anyway, so great work being done, and I will actually take some of the things I've learned here to share with my colleagues in Madagascar. And God bless you. I have to leave for another appointment, but Waye Bimpe.
Très bon boulot et je partagerai toutes ces informations avec mes collègues en Madagascar.
Okay. Okay. I hope to see you back in November, and thank you all very much for taking part in today's activities.
Merci à tout le monde. J'espère qu'on va se revoir au mois de novembre.
Bye bye.
Bye bye. Bye bye. Toi, ça qui dit le abonné.
Hey, toi cinq.
Merci à tous.
Okay. Mashallah bin for bons.
Colin.
Botika la malamo binabans.